Hello and welcome to this episode of the Langford Academy. Today we're going to talk about laryngeal paralysis. This video is split into three parts. So the first one is going to be about diagnosis and stabilisation. The second part will be about the timing of surgery and when we should operate on animals with laryngeal paralysis. And the final part will talk about post-operative care both in and out of the hospital. I hope you find this video useful. My name is Meakin, I'm Head of Soft Tissue Surgery at Langford Vets, and we're going to talk through laryngeal paralysis. This video is part of the Langford Academy. If you find these videos useful, it'd be really helpful for us if you can like and subscribe, and do comment below if there's any questions you've got, and we're very happy to provide that follow-up. So as I said, the first part of the video will be about laryngeal paralysis, about the diagnosis and stabilisation. We're going to talk about a dog called Duke, who's a 9-year-old male entire Labradoodle. He's got a 2.5-year history of noisy breathing, coughing after drinking, and progressive weight loss and muscle atrophy. He's also more recently had an acute collapse on a walk with cyanosis, and he's then been rushed into your practice because the owner's obviously very concerned about him. So initially, I think one of the most useful things is just to listen to these dogs, just to try and hear what sort of noise they're making, because that can really help you localise where in the respiratory tract the noise is coming from. So if you have a listen to Duke now and listen to his breathing pattern, try and work out if the noise is on inspiration or expiration, and also what sort of description you'd give to the noise. So hopefully you all heard that. So for me, that dog has got noise on inspiration, and it's a fairly high-pitched wheezing sort of noise. So that's really helpful because that helps us localise it to the larynx or the upper airways. And as I said, this video is about laryngeal paralysis, so it's very obvious what this dog's going to have. But for me, this sort of breathing pattern and this noise fits very nicely with that. So you can get a lot of information just from listening to the dogs and having quite a hands-off approach. Obviously, if this dog was coming truly collapsed and cyanotic, you'd need to be more sort of quicker with your interventions to try and stabilise things. But if you've got the opportunity to listen to them first, that can be really beneficial. So when you examine Duke's, he's got an inspiratory stridor and he's dyspneic. There's a few other things going on. So doing a triage examination, his heart rate is 156 and he's got fairly weak peripheral pulses. So suggesting that he's probably not got great circulatory volume, so slightly hypovolemic or other reasons for him to have weak pulses. His rectal temperature is 41.8, so obviously quite hot. And there was no further examination performed at this point because he was starting to get stressed out. So what should you prioritise? So we've already said we don't really want to go straight into doing a really thorough clinical examination. We will want to do that at some point, but at the moment our priority is to try and get him nice and stable, and there's clearly a few things that need addressing. So this is how I would approach him, but obviously there are different ways of doing this. So for me, the first thing is just to provide some flow by oxygen, which we're showing in the picture here. So if they'll tolerate it, we'll use a mask. Otherwise, you can just hold the breathing circuit nearby, because the main thing is that if you cause stress, you're going to make the laryngeal inflammation worse, and you're going to cause more of a dyspnea, which could even lead to obstruction. So we do need to be fairly hands-off and try and keep these animals as calm as we can. So flow by oxygen if the animal will tolerate it. I'd then usually reach for some sedation. I'd typically give this IM unless he's a really good animal, because again, we don't want to cause stress by placing an IV, so better to give IM if we can do. And for me, I'd typically go for acepromazine and butorphanol, because that gives a really nice plane of sedation and can really help these animals when they are struggling. The next thing for me to address would be the temperature. So 41.8 is getting quite hot, and really at the level where we would like to start actively cooling them. So for us, we'd usually do this by placing, we've got a paddling pool that we put in our ICU and fill with cool water, but we just find that wetting the animals is usually the best way of doing this. So they do need to be properly wet, so not just putting a wet towel on them or damping them down. We prefer to sort of hose them down if we can do, again, without causing too much stress. At this point, we know we've got weak peripheral pulses and we've potentially got a high heart rate, so we want to try and give some sort of circulatory support. So that would be the point where I'd then try and get an IV in, do an initial blood gas if we've got that facility available, and then start to give some IV fluid support. And typically we do this as giving fluid boluses, so usually around 10 to 20 mils per kilo to start with, see what effect that has on the heart rate and the pulses, and as long as we're going in the right direction, we could then switch to maintenance fluids, or we could give another bolus if needed to try and get on top of things. Occasionally these animals will then get really bad, so either they'll present like this or they'll just not respond well to your interventions, they'll start to get more stressed, and they'll get into a bit of a vicious cycle where they start to become really obstructed. And at that point you may need to consider intubation. So if they're really struggling, they're going cyanotic and they're actually not breathing, or they're getting so bad that you think they're about to arrest, that would be the point when we'd induce anaesthesia, intubate them, and then we've got a bit more time to think about what we're doing. So I would only do that as a very last resort, because this isn't the sort of animal where we'll want to do a laryngeal exam when they're getting so stressed and worked up. That's something that we'd ideally wait to do later. But as I say, some of these animals will need that early intervention. The difficulty though is if you do intubate them, they can be really hard to wake up. So you'll try and wake them up, they've got all this edema around their larynx, so you have to anaesthetise them again and so on. So at that point you may need to consider doing something else. Often at this point we'd reach for a tracheostomy tube, and we'd place that to allow that recovery, allow the rest period for the larynx for all that inflammation and edema to go down. There are some other options that people have described, so things like doing a mannitol soaked swab and placing that on for a few minutes, which I've used that as well, and that seems to work quite well the times I've done it. But as I say, that's a short-term solution. You may need to consider a tracheostomy to allow that animal to be recovered from the anaesthetic. So at the moment we've got an animal where we've diagnosed an issue with the upper respiratory tract. We're sort of thinking it might be laryngeal paralysis based on the signalment and the other things that are described in the history, but actually we've not diagnosed that yet. So at some point we do need to actually make that diagnosis. There's probably a few other things we'd like to do first. So at this point we're then hopefully in a position where the animal's a bit more stable. So at this point I would like to ideally do a full clinical examination. So we've done that in Duke and that was all unremarkable. We'd also then like to look at his neurological examination, because I think we said earlier there's been a few signs of him slowing down on walks and struggling with exercise over a longer period of time. And actually, as is often the case with these animals, he did have proprioceptive deficits in all 4 limbs. So we're then thinking, well, is there some sort of polyneuropathy going on which could explain the laryngeal paralysis and the proprioceptive deficits in the limb? And one of the other things we'd often consider at this point is testing for hypothyroidism, because that can be a cause of laryngeal paralysis and polyneuropathy. So if these animals are hypothyroid, we would then want to supplement the thyroid to try and stabilise that a bit further. So I'm not going to go into lots of details about that, because that's something that's beyond the scope of this lecture. So to confirm an animal's got laryngeal paralysis, we do then need to do a bit more, and really the only test we have that's reliable is doing a laryngeal exam under a light plane of anaesthesia. But we do need to be quite careful when we do this, because obviously all of the drugs we use for anaesthetics will cause muscle relaxation, and so if the animal is too deep, then they will look like they've got laryngeal paralysis where actually they're just a bit too deep under the anaesthetic. So for us, we use the drugs that we're used to using. We don't use anything different. Just whatever drugs you're most used to giving, they're the best ones to use. But just give it really, really slowly. And the way that we know these animals are awake enough is that they should still have some voluntary jaw movement. So clearly we don't want them to be awake enough that they're going to bite us inadvertently, but we do need to have that voluntary jaw movement to know that they're not too deep. As long as that's the case, we're then looking for when the timing of the breathing, so we want people to call inspiration and expiration to make sure we're really getting an accurate idea of what's going on with the larynx. So obviously the larynx should abduct during inspiration and it should adduct in the rest period. So sometimes they'll look like they're abducting when actually they're on expiration and they're sort of blowing the larynx open. And so really we do need to make sure that abduction is timed, it's coordinated with inspiration, and then we know the larynx is functioning normally. We'd often do another couple of things alongside this. So ideally, if the animal's compliant, we'd like to get a conscious thoracic radiograph, and that will allow us to assess for aspiration pneumonia, which is quite common in these dogs, and also if the animal's got some sort of megaesophagus, which they can get alongside their polyneuropathy. So the summary for Duke then, following this initial period of stabilisation and diagnostics, is that we're pretty sure he's got laryngeal paralysis with a sort of concurrent polyneuropathy. And really then the question is, does he require surgery and when should we operate? And also what surgery should we perform? So we're going to cover this in the second video, so have a bit of a think about those things and then hopefully you join us for part 2 of this video.